It's the True Sports Physical Therapy Podcast. Tune in, you might just learn something. Catch all of the full episodes on all streaming platforms, and as always, the link is in the bio. And welcome back, everyone, to the True Sports Physical Therapy Podcast. You guys are an audience of outstanding sports PTs, and you probably already know my guest, John Rusin, Dr. John Rusin. Welcome to the show, John.
Hey, thanks for being here.
This was well worth it for me to track your ass down. So thanks for finally making time. And I know you'll be a great asset to our audience. So give us a little bit of background, as if we don't know who you are. Tell us how you got to where you are and what it is you spend your time doing all day, every day.
Yeah, well, I'm going on year 19 as a personal trainer and strength coach. Trained my first athlete nearly 2 decades ago. And today, my life, my profession, my work with athletes and clients looks totally different than when it started. But I'll give you the 101 here. I was an athlete growing up myself. I took it to the Division I level, ended up as a Division I strength coach, and ended up in physical therapy school of all places, doing a doctorate there, and then figuring out 3.5 years in that I want to just go back into strength and conditioning. That led me into professional sports, where I spent about 10 years working with baseball, basketball, football, and then entering into Olympic sport. And everything changed at that point because I became a father. I moved to Madison, Wisconsin. We don't have pro sports here. And I started doing a lot more on the education side of things, writing articles, doing seminars. I ended up traveling the world, doing my pain-free performance specialist certification that's certified almost 20,000 coaches and therapists in person since 2019. So it's actually the biggest and the fastest growing certification on earth today. But all of that, today I focus in on health, performance, and longevity. And a lot of my clientele, it went from athletes about 90% to general fitness population 90% today. But I also have a handful of high performance athletes that are still looking to be healthy and perform at the top level.
Yeah. So this is what I love about your background is just the blending of those worlds of performance, strength and conditioning, and then obviously getting your doctorate in physical therapy, understanding all the pathology side of things. So let's talk a little bit about where those worlds intersect. As a strength coach, tell me what it is that us sports PTs tend to leave out. What are the biggest mistakes we make in terms of our exercise progressions and then eventually getting these athletes to just strength and conditioning?
Yeah, one of the biggest limiting factors for any type of clinician today is just the frequency, the total duration of time, and the plan of care that we have our hands tied behind our backs a little bit on, because we simply don't have any of those things lining up to do our best work over the time period that we need to do it. So many times you only have X amount of visits or X amount of time per visit, and all of a sudden you know what needs to get done, but you need to make concessions every single treatment session to be able to get them good enough to move on. That's where I tend to come in, take care, and create bridge programming and bridge client care for athletes that are maybe 70, 80, maybe 90% of the way there after pain or injury or burnout. And then we try to bridge that gap a bit, and then from there, just go into a pure performance model. But one of the things that is the toughest today is that we know how powerful loading, how powerful exposure, how powerful strength can be to the human movement system, but we aren't able to actually give a strength and conditioning style training effect in the clinic. And that's one that is a caveat, but it is something that can be super powerful. But it's also the power of your network and being able to cross-pollinate within professions.
Yeah, I love that. So what is it that you think prevents us from doing that in the clinic as PTs?
Money. It's hard to be reimbursed.
Say more. It's hard to be reimbursed
for that. And it's also time. When you look at trying to have a holistic approach to health and human performance, we're not talking about 20 or 30 minutes here or there. Many times, if you're seeing somebody 2 to 3 days a week, you're lucky. And in those 2 to 3 days a week, we need to be able to distribute certain movement patterns, certain prehab and rehab protocols, and be able to actually give somebody exactly what they need to not only get better, but to be better than when they got hurt in the first place.
Yep.
That takes hours a week, not minutes a week. And many times we're co-managing different patients and different patient loads and streams. And depending on the aspect of physical therapy that you're working in or the size of the profession, this can be a very tall task for many people where it gets watered down a bit, just being honest.
Yeah, so that makes a ton of sense. That's one of the things that we focus on at True Sports is giving the appropriate amount of time for a clinician with an athlete to make sure
Huge.
that we can load, right? And that's super important. And I think to your point, a lot of places they want to do that. They haven't figured out the business construct, and that's your money point of trying to carve out enough time. How do you keep the lights on if you're spending so much time with a given patient and you're in network, et cetera? So I think those are a lot of things that you can brainstorm around. Now, you mentioned your pain-free performance certification and how popular that is. Tell me why it's the fastest growing certification on the planet.
We teach a system. We don't teach a tool. We don't teach a single method. We're not trying to sell you something after. We're teaching the system to human movement optimization. And I think the reason that people gravitate towards it is because who doesn't want to feel their best? Who doesn't want to move, feel, and function pain-free? And the name is an interesting one because it's not pain-free like, hey, you're never going to get injured. You're never going to have pain ever again. Train with me and my secret methods. That's not what this is. It's looking at how do we manage a painful person in a training effect. And that's going to be 85+% of the population walking into the average gym
Yeah.
today here in America. So when we think about specializing in something like pain management in a training response, this is going to be something that yoga instructors are interested in, Pilates, physical therapists, chiropractors, personal trainers, strength coaches. We have over 300 physicians that are certified. And I think
Awesome.
it's just something that everyone is aspiring to do, to move well, to be able to train like a human being and have a construct and a system that is repeatable and adaptable based on the person in front of you.
Yeah, that's super enticing. Great sales pitch. Sounds like you've made it once or twice before. Okay, so let's kind of dive into that system. So you have an athlete who is by and large healthy, but they have some cranky shoulders. Maybe they have some rotator cuff pathology or impingement or whatever it is. Maybe some labral pathology. Can you just walk me through how you approach that athlete and how you can navigate around some of the pain they may present in a given shoulder program or upper body program?
Yeah, so one of the things that we have popularized over the last 2 decades in the fitness and the sports performance industry is assess first and train second. And this is a really difficult construct to break down because many times today, again, time is money, like we just mentioned, and the athletes are more shiny object syndrome than ever before.
Hmm.
We go in at a movement style auditing approach where we train first and assess second. That is mind blowing for many people that are like, what do you mean? You
Yeah.
don't look at internal and external rotation of the glenohumeral joint before you have somebody do a row or a push up or a bench press. No, we look at the pattern because pain-free performance is all about auditing the human movement system. That system for us is the 6 foundational movement patterns: squat, hinge, lunge, push, pull, carry, and elements of rotation within every single pattern, and also acting as an addition sign to create global movement. So the first thing that we look at in terms of a movement system for an athlete is them actually getting in, starting to move under speed, move under load, move under fatigue. And at that point in time, we run our pseudo screen for all 6 movement patterns. And then we're able to break down our movement patterns into more isolated areas that we can look at in terms of looking at mobility or stability restrictions, looking at movement dysfunctions or a motor control pathway that's just not quite there, and then able to audit and look at what the linchpin is for our work together. It's very easy to say, hey, I'm a baseball player. My shoulder hurts. What should my training look like? I've never seen you move. How am I supposed to set up your program? Seeing somebody move and not only just moving through a body weight pattern, but under speed challenges, under load challenges, under fatigue challenges, works out very, very well for auditing for a linchpin, which is going to be the number one area or site or movement or skill that we can improve that has a domino style effect in improving other aspects of the human movement system.
Okay, so don't give me that crap that you're not a clinician because you talk like a freaking clinician. So Give me some of those linchpins. What are some of those linchpins that you might find, and then how do you fix them?
This is super interesting because today my Major League Baseball players, my NFL players are looking very, very similar to my 45-year-old mom's of three, to my 65-year-old retiree that's playing golf, and to my 22-year-old return to fitness training program after too much time desk jockeying.
Yeah.
The more time that goes by in my career, almost 2 decades doing this, people are looking more and more similar, no matter their physical presentation or their physical specialty in sport or in activity. And you go by and you say, like, what the heck? This guy's making $3 million a year playing third base for the Milwaukee Brewers. And he looks exactly like this lady who's never played a sport in her life, but she's driving her kids to soccer 4 days a week.
Yep.
What's the deal? And many times, the things that we see are over and over again present due to just our disuse of our human movement system today. It's a host of myriad of different issues around sedentary living outside of the gym, sedentary and postural deficits when we're looking at being on the keyboard, being on the phone, driving more, commuting more, just not people moving throughout their days. And this really looks at shoulders, lower backs, and the thoracic spine being one of the key linchpins for almost everyone that I see. If I were to say one that I see regularly that will be across all movement patterns, across all physical challenges and spectrums, it would be the thoracic spine and its ability to move and dynamically stabilize the rest of the entire chain. That's the one that I'm seeing chronically over and over again.
Okay. So let's dial in on the thoracic spine. How do you diagnose that as the given restriction? How do you fix that as the given restriction?
So it's an interesting one because it is a predictor of front-sided shoulder pain. We have a lot of literature behind that.
Yep.
It sits right adjacent to the scapula. We have a lot of literature on scapular dyskinesis. And
Yep.
then it also sits right above the lumbar spine, which is through the last 10 years said that this is the most injurious site on the human body in Western society. Well, guess what? In the active population, the people that I'm working with, the shoulder's the number one, the lower back is number two. But these two things are many times intertwined together. You get one with the other. And the thing that connects both of these things is the thoracic spine and its ability to function not only as a dynamic mover into flexion, extension, side bending, and rotation, but the ability to actually create some stability so the scapula can move the way that it was designed to move. 16 muscles encapsulating this bad boy. We need to be able to design something that allows us to basically give ourselves a central starting point for success that can then display at the shoulder and at the lower back.
Yeah. So what compensations do you see? Or I guess as you're challenging them with speed, with load, with fatigue, what do you see the thoracic spine doing in compensation? Or maybe that's pathologic. And then how do you cue it, or how do you correct it? Or what are your correctives around it?
Yeah, so many times the T-spine, we really like rotational drills. We really like side bending based drills. And I like a combination of dynamic and static stretching, especially with integration of overhead pattern at the upper extremities. But many times we just see people that are kind of locked into a little bit too much kyphosis, which isn't a huge deal. But when you can't reverse that kyphosis and actually get into somewhat of a neutral or an extended position, that tends to break down the rest of the patterns and the rest of the adjacent joints to their functional abilities. So when looking at that, we really want to have that as the first one. It's like, can we move through a full range of motion? Oh my God. I don't think I needed a doctorate to diagnose somebody with a full range of motion at a joint or a spinal segment. But we're looking at extension, flexion, side bending, and rotation. And then not just isolating those, but looking at how they're actually moving when all of these movements are synergized together in those ancillary based movements, those oblique movements, the ones that we actually see in real life. So being able to have that first is huge. But that's only the starting point.
Hold on,
Looking
let me cut you off for a
yeah.
heartbeat. So tell me how you're looking at that. How are you coaching your students to look at that? Are they seated, hugging, and you're looking to move through all these ranges? Or give me an example.
So this breaks down into the movement patterns themselves. When
Yeah.
you're looking at squat, hinge, lunge, push, pull, carry, the squat hinge lunge, lower body directed patterns. We're looking at the thoracic spine to actually maintain neutrality through loading with these patterns. And it is very rare that somebody can actually move through the 3 cardinal lower body movement patterns without some sort of compensation that ends up into a forward dump, and it ends up into a hypercompensation, either at the lumbar spine, at the pelvis, or at the shoulder complex itself. So that's kind of square one. So those are the first patterns that we look at. Like, can we actually even maintain neutral? And then from there, we look at the ability to break away from neutral and go through more of a range of motion that is dynamically stabilized. This is done in the push and pull patterns. The ones that I like, nothing sexy, but they work extraordinarily well, is the standard push-up, and then a standard inverted row using a suspension trainer, or if you don't have one of those, a barbell and a rack at about hip height. And being able to look at the ability to push and pull with extension and flexion being present with a bilateral pattern.
Okay, so they present with a given deficit, so they're not able to stabilize. Maybe they're falling too far into flexion. Maybe they're hyperextending. Then what? What's your next step? What's your corrective?
So next step is to actually look at all of the patterns and make sure that that is the thing that we're actually looking at, because many times we can see one test in one result and then one corrective that can magically fix it. And the reality of people today is that they're dealing with multiple issues at multiple times in their lives. So the average person will come in with 2.5 linchpins, meaning that, like, hey, their lower back hurts, their shoulder doesn't move, and the thoracic spine hasn't seen rotation in 2 decades.
Yep.
And then we have to start prioritizing what we're actually going after first. I think one of the biggest drawbacks to a corrective exercise mindset, even though we do corrective exercises almost every single training session, is that we think that just by fixing the motor control or fixing a mobility deficit, that we can then integrate directly back into the pattern. And that's the old corrective exercise guru mindset, is that, hey, I am a fixer. And then once I fix this, it automatically shows back up in a complex motor pattern. Many times it's not quite that simple. So what we do is actually make sure that we're looking at all the patterns. And then it's not just the T spine, but we're looking at the shoulders, we're looking at the hips, and then we're actually looking at the ability to use ground contacts and hand contacts to create some sort of synergistic irradiation effect. You know, all those things, many times the basics and doubling down in the basics tends to unlock a linchpin in the movement system more than any corrective exercise ever could. And that's a big reason when we actually go through and screen the movement patterns, then we look at restoring a sound pattern just with some simple cues, some simple fixes. And many times that starts out with being able to breathe, brace, and then move around the pillar complex. Shoulders, hips, core together with the use of ground force, hand force with irradiation.
Okay, so I want to come back to irradiation because I think that's a buzzword that doesn't often get well defined. So put a pin in that. We'll come back to that. Give me a couple for instances of how you begin to integrate it into a more complex movement pattern.
Yeah, so we would take something in a system that we use called a 6-phase sequence. A 6-phase sequence allows us to, once we identify a linchpin, we go directly at it using different modalities in kind of an on-ramp for your movement system. What this breaks down to is it's an integration of a phase 1 soft tissue, phase 2 stretching, phase 3 corrective exercise, phase 4 activation, phase 5, the movement pattern itself, and then phase 6 is central nervous system stimulation around the patterns and around the planes of motion in which that pattern occurs in. So we tend to go directly into our system and start to address that by 6 different phases that couple and synergize together to then create the best possible solution for when we go and actually train to change and alter that motor pattern.
Okay, get into the last of the 6 because I understood the first 5. Talk to me about what you do with the 6th.
So the 6th, think about this as athleticism and power. So we're actually challenging the movement system, not through load, because we're not prepared to load quite yet. That's the next step, that's training. But we're actually challenging it from the opposite end of the force velocity spectrum, which is going to be speed. So this is something that we really get a lot of power recruitment, very low, if not any loading, 0 to 10% of predicted 1 RM loading. But we're doing stuff like jacks, jumps, short sprints, upper body throws and plyometrics with the medicine ball, and being able to have coordination of the upper and lower body working together around that central linchpin.
Hey guys, quick pause and a quick shout out to this new masterclass that we just launched here at True Sports Physical Therapy. Myself and Dr. Tim Stone put together a masterclass of ACL rehab, and we call it From Table to Turf. And the reason we call it that is because it's going to teach you exactly how to get your athlete all the way from post-op day one with the nitty-gritty of regaining all of that range of motion, with the tips and the tricks that we use here at True Sports Physical Therapy that gets our athletes better, faster, and stronger. And that's early. And then how do you progress that athlete all the way onto the field with a ball in their foot or a stick in their hand or whatever their sport is, and teach them how to accelerate, how to decel, how to change direction, all the mechanics that go in there. What drills do we use to get our athletes exactly where they need to be back on the field and even better than before injury? And I want you to sign up for that class. Now, you can find it on our website. You can shoot us a direct message and just say, hey, send me the course. It's right now on sale, so make sure you sign up now. It is fully accredited to get you all of your continuing education hours. Sign up for the True Sports Masterclass ACL From Table to Turf. Thanks, guys. Okay, so put all of that together for me. Your six phases.
Yeah.
With a T-spine deficit
Beautiful.
that you're working on.
Yeah, this is one of the most common 6-phase sequences that we do for the T-spine. It starts out with the foam roller right between the scapula, and we're going oscillating between and being able to have 3 different positions, one with an extension of the arms up overhead, one with the hugging of the arms coming into flexion, and then one having your butt on the ground, the foam roller not moving, and you flexing and extending over it, integrating the breath with an exhalation and an inhalation on cue. That should only take 1 to 2 minutes.
And where are you putting the breathing?
So we are exhaling fully as the thoracic spine is extending to its full excursion into extension, or the available extension point.
And that's because as you exhale, tell me what should be happening at the T-spine. Like, why are you coupling exhalation with extension?
It has nothing to do with the biomechanics of the motion. It has to do with the response of the nervous system. So anytime we're doing foam rolling or stretching, we want to have a parasympathetic drive. We want a relaxed response. And anytime you get to that bottom of that exhalation, we are actually at our most relaxed moment. And that tends to centrally de-stress the entire system. So we're able to actually do that. So many times, a lot of the things that we're doing is looking at how we're altering the central nervous system, the parasympathetic versus the sympathetic responses, because it's really hard to get a great effect from soft tissue work, whether it be manual therapy or self-directed, or even stretching or mobility or corrective exercises, if we're all juiced up into sympathetic fight or flight mode.
Okay, so do you apply the breathing techniques at all of these given phases?
Correct.
Okay. So that makes a lot of sense. And again, just to summarize, your rationale for that is you're retraining the central nervous system to then better maybe embed these functional patterns as we go out and use them.
Exactly. And there's some pretty captivating research on both soft tissue and stretching protocols with mobility or flexibility. And it really shows that if you're not having a meaningful parasympathetic breath during soft tissue or stretching, you may as well not do it at all.
Yeah.
And then everyone goes, hey, stretching is worthless. Hey, soft tissue work. Never put your hands on your patient. Don't have them foam roll. That's BS. What we need to be doing is taking a mechanical property or a mechanical input to the system that ends up centrally, and then coupling that with something that happens centrally, which is a vital metric like your breath.
Okay, but you would say, or maybe I would say, it is not worth putting your hands on the patient if you are not coupling it with the central nervous system driver or involving the patient in the process, as opposed to them just being passive during that modality.
No doubt. When time is money, when we want to get the most out of our treatment sessions, we want to have active patients. We want an active ability to do something to help us as we're doing things onto people. Many times people think they're just rolling in, they're going to get a nice stretch, get some soft tissue work, lay on the table, text while they do it. That's not what a great clinician does. And what a great clinician does is takes a manual therapy technique, makes it a self-directed technique, and makes it habitual for that patient to go out and do on their own.
Okay, I love that. So that's phase one, and that's a great lesson for everyone listening. That if you really want carryover of your given interventions, you have to have the patient involved, voluntarily involved, so that they can incorporate your modality into their everyday life. That's going to start with maybe some breathing techniques, and then also teaching them some self-directed soft tissue manipulation with these breathing techniques. Right?
One of the favorite things that I
Okay.
do is have my clients go in and they know I coach the foam rolling the same way as I'd coach a 1RM deadlift. And the respect that I give these smaller modalities, it carries over into their daily lives. And the best Christmas present that I can give somebody is a $10 foam roller to sit in front of their TV when they Netflix and chill. Because that compounding effect of doing the little things over time, it far exceeds the expectations of somebody with a couple sessions.
Yeah. Okay, that makes a lot of sense. Okay, so keep walking me through these phases.
Yeah, so the next phase would be whatever we went in and foam rolled, which is the thoracic spine or that posterior shoulder girdle in this case. We would go in and do a stretching protocol there. One that I'm a big fan of is called biphasic stretching. So it combines some oscillatory movement-based stretching. Think of like 1 inch, 1 inch on, 1 inch off, 1 inch on, 1 inch off. And we do that for 30 to 45 seconds. And then we couple it with 20 to 30 seconds of an end range static stretch. And for this case, we would go right into trying to extend the thoracic spine, involve the hips, involve the shoulders. And this would look like a suspension trainer hinged over lat stretch. And this would have us in the overhead position. It would have us in a hip hinge position, a neutral spine, and the ability to get the fulcruming point, hopefully, at the thoracic spine, kind of like midway through that kyphotic curve, so we
Mhm.
can actually start extending those segments. And this would happen with the chest dropping an inch, chest coming up an inch, dropping an inch, coming up an inch, and trying to grease the groove and then sit out into that static stretch with more of a creep-based protocol.
Okay, and you're timing breathing with the suspension trainer stretching?
Yeah, and this one's not as big of a deal as like that extension over the foam roller with the full exhalation. What we want to do here is just make sure that we are extending the breath in, extending the breath out, and we're not breathing too fast or too shallowly. We don't want to increase our heart rate or our respiratory rate here. We want to do the polar opposite, which is stay in rest and recover mode.
Okay, love that. Okay. Next phase after your stretch phase.
Is corrective exercise. So this is the one, instead of going directly at the corrective exercise, we kind of line ourselves up for success, soft tissue, stretching, boom, the corrective comes in. I'm a huge fan of rotary-based thoracic spine drills, quadruped thoracic spine rotations, sideline thoracic spine rotations with arm sweeps, anything that gets us actively rotating, side bending, extending at the same time is like gold for me. These drills, there's a myriad of them. We probably cycle in 5, 6 different drills routinely, probably have a Rolodex of 20 different drills. But if you're getting started, down on all fours, get your hand behind your head, don't rip on your neck, but then rotate fully. And this is an important one to have that exhale come when we're rotating and extending. And I don't like counting reps here. So in corrective exercise, our goal here is to have that aha moment to be like, oh, I've never felt it like that before.
Mhm.
That makes sense to me. That's motor control and skill acquisition. That's what we're looking for. So we have people do a couple reps on the left, couple reps on the right. We have 2 minutes on a clock and we have them play with this motion. Unguided play so we can have those aha moments. We can have those light bulbs go off and hopefully feel a little bit something different. And something different for us means that it's smoother, it's more sequential, or it gained more range of motion, or hey, it didn't hurt when I
Didn't
did it.
hurt.
Didn't hurt my
Mhm.
shoulders, didn't hurt my lower back. This feels good. And those are going to be some key metrics to every corrective that we do.
Yeah. Okay. Love that. Now, then once you move from your corrective exercise, dude, you are a physical therapist. Okay. So once you move from your corrective exercise, now we hit.
We go right into activation drills. So thinking about the thoracic spine moving into extension, that's what we just tried to gain in the first 3 phases. We want to go in and try to restabilize that newfound extended range of motion. Many times this happens with a lot of our banded shoulder warm-ups. So I'm a big fan of banded face pulls, banded pull aparts, and those are going to be the two ones that we really like to pair in with the thoracic spine extension deficit.
You
And
love face pulls, dude. I've been watching you do face pulls for the last decade.
I love face pulls because they work for almost everyone. Pull aparts are great, but I have had clients and athletes that have fallen through the cracks on pull aparts.
Yeah.
Face pulls, if you can do them correctly, and then if you can optimize them for a specific shoulder blade need or shoulder blade position, they become a beautiful catch-all for almost everything that we want to do. They're horizontal abduction. They extend the thoracic spine. They give us external rotation at the shoulder. They guide eccentrics into internal rotation. They have skill. They have three-dimensionality. If you pull the band apart between your hands, you can go down into a half kneeling position. You can get a hip flexor stretch. They're awesome. There's no need to ever skip a face pull because there's so many different ways to get so many out of them. And the golden thing about face pulls is that they perfectly reverse the piss poor posture that we find ourselves in, for me, 8 to 10 hours a day. So heck yeah, I'm going to be doing face pulls every day personally.
Yeah, and this is a great example of what I see so much on the clinical side in sports PT, which is people can do face pulls till the cows come home. If they're not doing it right, they're missing so much of the effect, right? And it's really easy to breeze by these things. And so all the little nuances that you just mentioned are so important when you're cueing them, explaining to your patient why you're doing it, or to your athlete why you're doing them, what they should be feeling, what every piece should be moving. Give me some errors you usually see on the face pull.
All right, face pull 101. If you can just do these three things, you're going to be better than 99% of the people out there. First thing, we are not pulling the hands to the face, even though it's called a face pull. Think about driving the elbows backwards, and you have a target of the band most likely approximating between your chin and your nose. I don't recommend hitting yourself in the eyes, even if it feels good on the upper back. That's just a no-no. So one, go with the elbows. Don't have the focal points be the hands. Number two, it's not just one single position for you to have success with the face pull in terms of the anchoring point or the height of where that band or the cable stack is coming from. 7 out of 10 people, they ride high at the shoulder blades. They ride into internal rotation at the shoulders. This means that we want to go the opposite direction. We want to anchor high, pull low. This allows us to actually get the shoulder blades downwardly rotating, depressing and retracting, and it allows us to have the lats, which are a key stabilizer of that shoulder girdle. And it's a huge broadly attaching muscle on the backside of the body. It helps us have secondary stabilization into depression of the shoulder. Beautiful, beautiful thing. On the opposite side, if you're somebody that rides low on the shoulder blades, I have a lot of my overhand throwing athletes ride low, we are going to be anchoring low and pulling high. That's going to allow more external rotation of the shoulder, and it's going to have less load capacity, but more internal, external mobility. That's a really good thing. And the positioning is number two. Number three is the ability to actually execute the pattern with the correct tempo. When we're thinking about executing, you want a little bit more of a dynamic pull, so a little bit of speed behind the pull. You want a peak contraction once you get those elbows back, once that band comes to your face. Peak contraction, but not an isometric, and then an accentuated eccentric, maybe 2 to 3 seconds out. That is the perfect face pull rep. Fast rep, flex the contraction, 2 to 3 second eccentric out. If you can simply do those three things, like I'll never have to shoot another video for Instagram on Facebook. I'd be so happy about it.
Yes, but I would be remiss if you never shot one of those. So I'll tell you what I'm loving about your presentation of this. Number one, your excitement around what sounds like a very simple exercise. Two is your attention to freaking detail. And this is great for one, outcomes, but two, getting patient buy-in. If you can lose your mind as a clinician to your patient about how important these nuances are, why they're important, what's going on functionally, that patient is going to be eaten out of your hand. They're going to come back for visit 2. And that is 90% of the battle when you're trying to make this a everlasting relationship with your patient. So kudos to you for really owning that. I tend to do the same thing with clamshells, because if I had a nickel for every
Yeah.
time a patient came
Yeah.
in, it's like, I did clams in my last PT, it didn't help. Like, show me your clamshell, and then losing your mind about doing it exactly spot on perfectly and why that's important, you're going to get better results, and your patients are going to freaking love you. So I love hearing this level of focus with a face pull. Can you just get into what you mean by riding high, riding low of the scaps?
Yeah, so the scapula, they sit on the backside of that thoracic cage. And based on maybe muscle dominancy, lack of mobility, or just postural deficits where we tend to get tight and weak, we have different positions of the scapula that are going to be different for everyone, but maybe they've creeped into positions that just are less than advantageous for physical form and function. That tends to be us every single day based on the computer and cell phone use. So we don't necessarily notice until we notice with shoulder pain or neck pain or lower back pain. And that's the time where we actually want to look at where the scap is, but more so, it's not where it is statically, it's where it can go in terms of a full range of motion. Back to the basics. We
Hmm.
want a full range of motion being able to have upward rotation, elevation, and protraction happening at the same time. And we want full range of motion there. We also want full range of motion down on the backside in the opposite directions. And then we look at the culmination of both of these things happening. That is what looks left to right, hopefully symmetrical, and hopefully through a full range of motion. Almost no one has a full range of motion. And the mistake that strength coaches or personal trainers make is like, oh, my client's shoulder blade looks like shit right now. So you know what? We're not going to mess with that. Down and back, down and back, down and back on everything. And all of a sudden we're like, no, like down and back, I guess, is a little bit better than getting hurt, but like you're not going to get better.
Yep.
So looking at that full range of motion is key, but just restoring things to the way that your body was naturally designed to build, not to be too like bro biomechanics on you, but that's the starting point is like, do the biomechanics look pretty good? Because, chronic stress, fatigue, overload through patterns, it starts with biomechanics. And then of course, there's going to be a deeper element to the science behind movement control and execution.
Yeah, you make a good point with that. Just pull your scaps back. And I think I just saw a bunch of stuff on how important it is to get your scaps back. It's all about scap retraction, and that's how you defeat anterior shoulder pain. And I think we're missing a massive piece if we're not looking at how well can the athlete protract, how well can they control protraction. That's why I love your point on the face pull, controlling the eccentric portion. But I think that's a huge that's low hanging fruit. I think it's totally glossed over when rehabbing the overhead athlete, when you're not looking at whether that scap can protract, whether it can protract with all the things you just mentioned, under load, after fatigue, and with speed. Because that's the way you throw a baseball, right? And so you have to look at both ends and make sure that they can retract full range, full control, and protract full range, full control. You agree with
Makes
that?
perfect sense,
Okay,
but
good.
I think a lot of the dogma comes from, especially in the strength training community, is like, what do we do when we have a barbell on our back, when a barbell's on the floor and I pick it up on a deadlift, or if I'm laying down on a bench and pressing a bar off my chest? Oh, it's down and back. Like, I'm not arguing that it's not going to be down and back on the big three movements. That's 100% correct. We don't start there. That is the peak of our movement pattern pyramids at pain free performance. It's like we maybe aspire to get there someday, but there's a lot of pieces that need to come into play before. So when
Yeah.
you're looking at the push pattern, we start at push ups because it allows a closed chain, AKA the shoulder blades can, or at least are going to be challenged and audited to see if they can move through a full range of motion and see if they can be dynamically stabilized. In the pull pattern, we don't look at, like a dumbbell row, like with a chest support machine or something like that. We're looking at an inverted row. And even on something like the squat pattern, we're looking at the ability to have a goblet squat position with the first exposure to loading because it allows that position of the shoulder blades to actually become recruited and rotated.
Yeah.
And a lot of these things, vast majority of the activities that we're going to do in the real world, not in the gym, but in the real world and also in the gym, is going to involve slight degrees of rotation. That's just the reality of things.
Yeah, yeah. I think that's a point well made. With your pressing, with your chest pressing, at full let's say lockout, you're asking for protraction around the shoulder. And if you cannot control that protraction, I think you get in trouble. You're not going to stay totally glued into retraction through your press. So and you'll see it also, you'll see it on your inverted row, right? As you come towards an extended position at the bottom of that row, those shoulders protract as you fall backwards. It's not until you pull upwards that they're retracting. So it's an important piece that I think often goes glossed over. Um,
It
that's worth
it
focusing on. Go ahead.
does. It does. And one of the things that is a big predictor of injury, just from a biomechanical sense, is challenging a position that is a novel position that you have not had exposure to.
Yeah.
And this is huge. So if you're never using the full range of motion at the shoulder blade, you never reach that peak scapular protraction. And then all of a sudden you go and do it, and you do it under load, or you do it under speed, or you do it at throwing a baseball after 125 pitches in the ninth inning. Then all of a sudden you have this novelty effect that creates this motor control gap.
Yeah.
Basically, you don't know how to restabilize. You don't know how to gain that position, and you're going to be forced into that position, and your body's going to react, and it's going to respond, and it's going to protect. And many times it protects with a pain source.
Yeah. Yeah. Okay. Well stated.
True Sports Physical Therapy is growing like wildfire. We have 14 locations, soon to be more. We are throughout the state of Maryland. We're in Pennsylvania, in Lebanon, and York, Pennsylvania, as well as in Delaware, in Newark and Wilmington, Delaware. Like I said, so many more practices to come, and we always need outstanding sports physical therapists. Our treatment style is unique. We are one-on-one with your athlete for 45 minutes every single session. You do the entire treatment, you do the entire evaluation, and they are in state-of-the-art facilities where you have room to run, throw, and jump, and really get your athlete all the way back to on the field and better and stronger than they were. We also have outstanding salaries, comp structures, bonus abilities, 401ks, as well as a very strong continuing education offering, including in-house continuing education. And we're looking for you. Now is the time, as we are growing like crazy. Just shoot your resume over to Yoni, Y-O-N-I, at True Sports PT, or shoot us a DM, and we will hit you back. We will get you in for our unique, tried and true interview process, and really make a determination that this is the right place for you to grow your career and get your athletes better than ever. We can't wait to hear from you.
Now, one of the things I recently saw you post on was pulling out the need for grip when pulling. You were talking more about I think delts and keeping tension on the delts and not using your grip to pull up into a lateral raise, or you were supine kind of showing it on a pulley machine. Is there any room for that where you do face pulls without gripping and you just wrap it around your wrist or something like that?
Yeah, this goes back to what we were talking about before. Is just the principle of irradiation. Principle of irradiation happens at contacts of the hands, contacts at the feet, highly deep sensory areas of the body. You talk about your face, your hands, your feet, and we'll leave the last one to your imagination.
Yeah.
And when we're talking about irradiation, it can be a tool to amplify your strength and your performance, or it can be a tool that can actually take away from mind-muscle movement connection, maybe in a more intricate movement like a posterior delt raise, a lateral raise, or even something like a rotational base face pull. Anytime that you have the grip maximized, you have maximal muscular recruitment, and you have maximal nerve innervation that has all of those things kicking on from a motor unit perspective all at once. It's a really, really powerful thing. So if you're strength training right now and you're not gripping the weights as hard as possible, do that, get back to me, you can thank me later. But when people have chronic wrist issues, elbow issues, shoulder issues, neck issues, sometimes we want a little bit more of an isolated training effect, knowing very well the caveat is that there is no isolation, it's all integration. But we want to emphasize the area that we have a marquee emphasis on. So when we're thinking about doing something like a face pull that has maybe a band or an attachment that goes around your wrists, so you actually keep your open grip and actually move into extension at the wrists and the fingers, that allows us to bring down the load capacity, bring in the centralized training effect that is most likely going to be on the posterior shoulder girdle, and allows us to have just more concentration there, as opposed to have muscular recruitment at the wrists, at the forearms, at the biceps and triceps, and the entire kinematic chain of the upper body. So there are times and places that we do this, and many times it is going to be in the more isolated movements. It's going to be in the more isolated movements at the hips and usually at the shoulders. Those are the two areas.
Yeah, yeah, I think that makes a lot of sense. It makes me think that the creator of Jaeger bands was kind of ahead of his time, right? So, like, if you can get band attachments that wrap around your wrist, how much easier those and more isolated. To your point, you can no longer use grip. You're not getting that irradiation, but you're going to get increased, perhaps, isolation in the posterior cuff or shoulder.
Yeah, you think about anything with the shoulder, if your hands are gripping onto something, it's going to be a flexion dominant movement. Whether you like it or not, it's going to be flexion dominant. And it takes it from the irradiation all the way back up chain. When we are using gripless shoulder work, it's not only good enough to just not have the grip, we want to actually extend fingers, splay fingers, extend the wrists. That is a game changer in terms of changing it from a flexion-based movement into an extension-driven movement, and you can simply feel the difference. It's one of those things, it's like, oh, I don't quite believe that. Go do it.
Try it.
Do a grip, and then extend fully and do exactly the same face pull, and tell me what kind of recruitment you feel where.
And how would you carry that over to lower extremity?
Lower extremity, many times we want the dynamic moving side to be able to be free from foot contact. You could think about a good example would be like a single leg glute bridge with the opposite side moving up into flexion at a 90-90 at the ankle and the knee and the hip, and being able to have that key driver with the hip flexor be driving the movement, and you can feel it at the hip flexor versus having a bilateral glute bridge where you're really just fighting that because both feet are on the ground. So anytime that we can get into a unilateral base lower body where a limb is actually traveling through space, or dare I say it, we get people into the open chain at the lower body. I know it's like demonized now, like don't do leg curls or leg extensions, or you're not a functional physical therapist. Like, no, it's okay. We can get that stuff in as well.
Yeah, yeah. Especially, by the way, in the ACL population. That is
Yeah.
that is one of my
Yeah.
freaking pet peeves, right? Like how scared we
Oh.
were as a profession to avoid this open kinetic chain, but how important it is. How important it is in isolation, how important it is for tendon health and all those things to live open chain at times as a piece.
Absolutely. I don't know where that came from, but somebody demonized the leg extension machine. And to this day, not even in physical therapy populations, but in training populations, people are really worried about that leg extension machine.
Yeah.
They're worried that it's going to grind away their patellas, that they're going to end up with arthritis and all this other stuff. And it's like, I'll program it in every now and then if somebody has access to it. But just taking away the machine and looking at open chain knee flexion extension, that makes sense to me. And we do it in many different ways. We use reverse hyper, we use bands, we use cables, we use machines.
Yeah.
It is something very, very nice. And it adds to that lack of novelty. We want to be prepared for different positions, different loads, different kinematics at the joints.
Yeah, yeah. I will say across all of our clinics, the one machine which we insist on having is a knee extension flexion machine. And I think it got demonized. One, you're right about the patellar and the patellar compressive forces on the femur, which I think has been blown out of proportion, but also the tension on the ACL graft for some reason, we thought that that was a major problem. And studies more recently have just totally debunked that myth. So if you're listening out there and you're rehabbing ACL athletes, please stop being scared of the open kinetic chain. It is essential, especially when they're non-weight bearing. Like, I don't know what the hell we did with these patients before we kind of came around on that. But let's get past that. Okay, I want to bring it all the way home with your sixth phase. So
Yeah.
we went through the activation, we went through soft tissue, we went through stretch, we went through corrective exercises. Talk to me about what's next.
So we get into phase 5. It's the easiest of phases. We're simply training the pattern. For the thoracic spine specifically, you have the push and pull patterns. And the place that it looks very good is usually in the horizontal plane of motion to start, push-ups, inverted rows, or you can actually move into the vertical plane of motion if we're ready to actually gain that extended position, maintain that extended position, and then challenge it under load and under fatigue. So that is the ability to most likely set up a push-pull superset and be able to grease the groove of the pattern there and start practicing the pattern. We don't want this to be like a RIR of 0 or RPE of 1,000. We want to be able to just go in and practice the pattern. I break it up in 3 to 5 sets of 3 to 5 reps, about 25, 30 seconds in between, just so you can think about what am I going to look at improving this next set to be able to play with the pattern, because that's the goal of this entire sequence, is to rebuild this pattern, rebuild this region, and being able to integrate from isolation back into integration.
Yeah, I love it. And then that brings you up to what? Your power component?
Power component. So this is going to be straight up med ball. So being able to train the vertical and the horizontal patterns, we would think about like an explosive med ball slam up overhead, slamming it onto the ground. And then we would look at a hinged over med ball press, being able to ballistically push it into the ground on repeat. Again, we're thinking about low total volumes, maybe 25 reps total between those two exercises.
Okay, gotcha. Okay, and this you formulate as what? This is your warm up?
Yeah, so we can
Okay.
double. One is a warm up. We have a version of pain-free performance that gets taught all over the world for clinicians specifically, and this is a more robust therapeutic exercise session. I just lined it up where you should be able to get this done in 10 to 12 minutes, but there are ways to build this up into 35 or a 45-minute session where we have more exposure into phase 5 with actual strength training. We have more exposure into manual therapy techniques in phase 1 and 2. We have more exposure and more time allotment into corrective exercises and activation drills. And then we also have the culmination of power and performance at the end. So there are ways to manipulate this 6 phase based on the setting that you're in. Whether you have a patient for 10 or 20 minutes, whether you have a patient for 60 minutes, the things that we're doing with a multimodal approach to rebuilding the human movement system, I think these are the best tools that we have at our disposal.
Yeah, and I think this is where standard physical therapy, if you're going to use it clinically, becomes sports physical therapy, because now you're integrating all of these patterns. You're getting the athlete moving the way they would if they were practicing. They're working hard. They actually have to put on gym clothes, right? Like now we're talking about this is the way athletes move. This is the way we're going to train them. This is the way we're going to rehab them. And I think that's an awesome blending of all of your background. So thanks for laying that out. Still got to take that course, even though you just laid it out for us. But I think you did a great job of kind of working through that system and why it would make sense. And I think the example of the thoracic spine is a great one, because as clinicians, I think we are undereducated in the import of thoracic spine. And if you think it's a thoracic spine, what the hell do we do about it? These are great interventions to kind of incorporate. All right, let's move to our lightning round of today's session, Dr. Rusin. Ready?
All right.
Okay. What's the biggest mistake you made in your career and what you learned from it?
Oh, man, chasing performance only. I chased performance for my first 10 years of my career, and it brought me to some high peaks in terms of professional and Olympic sport. But when you grow up, when you mature a bit more, when you are a father and a family man and you're living in the real world and not just chasing that next medal for your athlete, you realize that we are a service-based profession. Physical therapists, coaches, personal trainers, we really give a shit about what we do, and what we do is help people. And I learned this, halfway through my career so far, and I realized that I wanted to do more than just bring somebody who's making all the money in the world and bring them back on the field on a Sunday after the last Sunday's game. I wanted to actually deeply impact people's health and wellness and be able to extend their longevity. And as cliche as that sounds, focusing in only on sports performance and then taking the principles from sports performance and giving them to people that actually needed them, vitally needed them, it's been the biggest pleasure of my career, because today I wake up every single day really focused on health and longevity and bettering people's lives. And I have the itch with a couple of athletes here, but it's vocational. It's vocational, and looking at the only important people aren't the ones that are athletes. If you're a sports performance physical therapist, everyone deserves the same level of care as an athlete.
Yeah, I love that. That's really well put, and definitely rings true. Okay, talk to me about clinically. What is something that you used to incorporate in your programming that you have totally moved on from?
So I used to manage a lot of clients and a lot of athletes from kind of like a hybrid perspective. So I would have my hands on clients. I would be doing grade 5 thrust manipulations and ART work, and then getting them into the training sessions. Today, as it stands, I am totally hands off. I will not put my hands on a client or a patient. And that isn't like, oh my God, I'm so smart now that I don't have to do that. But it's something that I think that in terms of its efficacy and its repeatability, being able to teach as opposed to do onto somebody,
Mhm.
the active process of teaching so they can establish it for themselves, I think it far exceeds the long-term play in terms of results.
Dude, I went down that same road. Like when I came out of graduate school, I was obsessed with manual therapy and fixing people. And
Yeah.
then all of a sudden, like, I started to read some of the literature on, how effective we are as clinicians at understanding what the SI joint is doing. Can we actually palpate and feel what the SI joint is doing? And once I started to see that, no, you can't, I'm like, what the F was I doing for the first 5 or 6 years, insisting that I look at everyone's PSIS? Rather than teaching movement patterns, and that's what you're doing is you're teaching and assessing movement patterns. It's a totally different world. um, so I think that makes a lot of sense. Tell me what you're in the middle of reading.
I am in the middle of reading my own book. We're 2.5 years in. Pain Free Performance will be on shelves where all books are sold in 2025, like halfway through the year. And
Awesome.
we are
Congrats.
so deep into this that I've stopped all like pleasure reading or educational reading. And we have 605 pages of the entire Pain Free
Oh my
Performance
god.
system. And it's going to be a beautiful thing. But I have a great co author, great publishing house. And we're trying to change the game in terms of making this accessible to everybody, a million people at a time. So I've been deep into that 3, 4 hours a day. And hopefully it's going to be done here soon. Like books should usually take like a year and a half, 2 years. We're going to be printing at 3 years at this point.
Okay, so what do you read before you go to sleep? What do you watch right before you go to sleep?
All right.
don't
So we
don't
do
tell me your own book.
Yeah, so we don't have screens in my house, so my son doesn't use screens except for like 20, 30 minutes of like a sports documentary or like a Netflix right before we go to bed. And my son, my wife, they're similar to me. They have a lot of energy. Like we put it all out on the line every day, working or doing sports or coaching or whatever it may be. So we're like ready to go to bed, and we go to bed at like 7:30, 7:45, and everyone's like, "Oh my God, you do?" Yeah, because we get up at like 4 in the morning the next day. My son doesn't, but my wife and I do.
Okay, that's intense. Tell me what your diet currently consists of.
So I do a whole foods based diet, prioritize protein, and really just gravitating towards like 8 to 10 different ingredients that really just do well for me. But nothing super crazy, balancing protein, carbohydrates, and fats, but it's all coming from whole food sources. No oils, no seed oils, no fast food, kind of like no garbage stuff. And that tends to do really well. I do have the advantage though, because my wife is awesome. She's a strength and conditioning coach as well. She really likes to cook. So she meal preps for us, and it really works because I have food on demand 24/7.
Dude, that makes it easy. Okay, so last question. What's the last cheat meal you had?
Oh, okay. Last cheat meal. So we go to Badgers football games, and cheese curds, like hell yeah, cheese curds and brats, because I'm in Madison, Wisconsin. Like that's our big thing here. So I partake.
Okay, and beer?
No beer. No beer.
That's where you draw the line.
Yeah, that's where I draw the line.
Okay, I love it. Okay, thanks for indulging us there. Tell me where we can find you, what we need to know about the whole world of John Russin.
Dr. John Rusin is on Instagram and on Facebook. If you want to learn more about the Pain Free Performance Specialist certification, is getppsc.com, GETPPSC.com. And then about 2,000 free articles are available over on drjohnrusin.com as well.
Yeah, and it's great stuff. You've been an awesome influence on my career. I was talking to our COO, Dr. Tim Stone, before I jumped on with you. I said, "What should I ask Russin?" He's like, dude, that guy changed my career. I've been listening to that guy forever. So your impact is obviously worldwide. Sports PTs love you. I just want to thank you for all the effort you've put in. You got a great product. You did a great job of breaking it down. So thanks for teaching me. Thanks for teaching my staff. Can't wait to continue to learn more from you. Thank you, John.
A high compliment. Thank you so much.
Yeah, man. Appreciate you. All right, guys, go check out Dr. John Rusin. Thank you so much for listening to the True Sports Physical Therapy podcast. Let us know what you loved. Let us know what you hated. Let us know what you think about me and John's hairstyle that was not coordinated. And just reach out. We are happy to hear from you. Thank you all for listening. Bye-bye. Bye-bye. It's the True Sports Physical Therapy podcast. Tune in. You might just learn something. Catch all of the full episodes on all streaming platforms. And as always, the link is in the bio.